Hi there. So my name is Simeon Mitchell. I'm one of the fifth-year residents. I think I know almost everybody here. And I'm going to do grand rounds today on ketamine and its uses in the emergency department. Before we get started, I just wanted to acknowledge some people that have helped me out with my grand rounds. So those are Andrew G., who is my supervisor, also Carrie Poulin, Dr. Butt from CHIO, Dr. Boyles and Dr. Thurger, all which provided some insight on ketamine and its different uses. And then also, I couldn't do grand rounds without thanking my study group that helped me survive this year. So our objectives today are to review the pharmacokinetics and pharmacodynamics of ketamine in the emergency department. We're going to go through some myths and see if they actually hold up to evidence surrounding ketamine. We're also going to look at the evidence and recommendations for using ketamine in a few different clinical scenarios. So those include subdissociative ketamine for analgesia, procedural sedation of agitated patients, its use in alcohol withdrawal, and then finally, its use in suicidality and depression. So let's jump straight in and talk about the pharmacokinetics and pharmacodynamics of ketamine. So if we go through a little bit of history, as you know, ketamine was synthesized in the 1970s, and it was really made because they wanted to make a better general anesthetic than PCP, because people were using PCP and that had a lot of agitation and problems surrounding that. So it became very popular in the 1970s, but then its use really plummeted and people stopped using it. And the reasons behind that were multifactorial. So at that time, propofol was invented, and that became very popular. There's also some concerns around people abusing ketamine and using it recreationally. And then there was the whole controversy surrounding increased ICP in ketamine. So it was really relegated to this horse tranquilizer that vets would use, and it wasn't really used so much in the emergency department. But we've seen in the past 20 years, and especially in the past 5 years, if you look at this graph, just looking at PubMed publications surrounding ketamine in the emergency department, there's been this big resurgence, and there's a lot of new publications about ketamine. So if we go through a little bit about how ketamine works, so we know that it's an NMDA receptor antagonist. We know that it's an indirect sympathomimetic, and we also know it's a dissociative anesthetic. And so what do we mean by a dissociative anesthetic? We mean that it induces this state of detachment from the outside world in which patients remain kind of in this cataleptic trance, sometimes with their eyes open, and they don't really perceive any pain. So we know that ketamine is very lipid soluble, and so it rapidly crosses the blood-brain barrier. It's metabolized in the liver and eliminated by the kidneys. But perhaps more importantly, it should be dosed based on ideal body weight, not based on actual body weight. And in terms of giving it intravenously, we know that it should start working in about a minute. And usually the state of dissociation lasts 5 to 10 minutes. Now, we can't talk about ketamine without talking about some of these classic dosing ranges, and these are critical for its use in the emergency department. So we know that from 0.1 to 0.3 milligrams per kilo, we're in what we call the analgesic dosing range. If we go a little bit higher, so 0.2 to 0.5, that's the recreational range. And you'll notice that some of these dosing intervals overlap, meaning that they're probably a little bit different in different people. And so usually in this state, you get some of the kind of psychedelic effects of ketamine, and you get a little bit of euphoria. If you go higher, so to 0.4 to 0.8, you get this partially dissociated state. And this is really the state that we want to avoid in the emergency department, because this is when people are detached enough from reality to kind of lose their inhibitions, and they'll get some of the psychedelic effects, but they'll find those very, very intrusive and very upsetting. So that's kind of when you hear people freak out or have a bad K-trip, it's usually in this dosing range. And then, what we're probably most comfortable using in terms of ketamine dosing ranges is the fully dissociative dose, and that's in the 1 to 2 milligrams per kilo. Ruben Strayer, who's done a lot of work about ketamine, kind of calls this the ketamine brain continuum. And the only thing that I want to show with his infographic here is that you see as you reach fully dissociative state, if you give more ketamine, the only thing that's going to happen in a healthy person is that it's going to last for longer. You can't really overdose on ketamine if you have endogenous catecholamines, which we'll talk about a little bit more in more detail. So let's go through a little bit of myths surrounding ketamine, and we'll see kind of do these hold up to the evidence. So the first one, I hope everybody knows the answer to this, but you hear people say ketamine shouldn't be used in cases of increased ICP. So this has been thoroughly debunked. So there's numerous studies that say that this is not true. Probably the best evidence that we have for this, it was a systematic review that had over 900 trauma patients. They looked at ICP, they looked at cerebral perfusion pressure, they looked at patient-centered outcomes like death and ICU stay and everything, and they found no difference or no ill effects of ketamine used for RSI in trauma patients with increased ICP. So this is officially busted. What about ketamine shouldn't be used in cases of increased IOP, intraocular pressure? So let's say you're seeing somebody that has a retroorbital hematoma and you want to do a lateral canthotomy and cantholysis and you want to provide some procedural sedation. Is it bad to use ketamine in this sort of situation? So there have actually been a number of studies that suggest that there's no change in intraocular pressure at doses that we're using in the emergency department. So if you would give horse doses, or you would give, maybe like 10 or 20 milligrams per kilo, then there might be some sketchy evidence to say that that could be a problem. But in terms of the doses that we're using in the emergency department, no problem with intraocular pressure. So this is also busted. What about shouldn't be used in patients with schizophrenia? So this one, everybody hears about this, and I wasn't really sure about the evidence surrounding this. There actually are at least one study where they asked volunteers with schizophrenia to get ketamine, and they found that you could actually induce psychosis in patients with schizophrenia. So really we would say that this is plausible. There's not a lot of great evidence, but probably we should be avoiding ketamine in this population. And then finally, you hear people say that we shouldn't be using ketamine in patients that aren't on a monitor. And my only response to this is like, no. This medication in an analgesic dosing range is probably safer than opioids, right? Meaning that there's probably less ill effects compared to opioids, and we'll talk a little bit about that. So I would say that this one is busted as well. So going through some take-home points just surrounding the background of ketamine, I would say that ketamine has different dosing ranges in the emergency department, which are crucial for its use. If we're giving ketamine as a single agent in the emergency department, then we should either be targeting the analgesic dosing range, so again, that 0.1 to 0.3 milligrams per kilo, or that fully dissociative range, which is over 1 milligram per kilo. And the evidence says that we should probably be avoiding it in psychotic disorders. And finally, as we'll see in the next few slides, there's a lot of uses for ketamine in the emergency department besides just doing RSI. So we're going to shift gears a little bit and talk about using ketamine for analgesia in the emergency department. So to kind of frame this issue a little bit, I'll show you guys some different patients, and you can kind of think in your mind if this is somebody that would be a good candidate to use ketamine. So, for example, a healthy 20-year-old with an open tib-fib fracture, a recovering opioid addict with acute pain, an elderly person with undifferentiated abdominal pain, and then finally, chronic pain patient with an exacerbation of their chronic pain. And so hopefully, when we go through some of the evidence, you guys will have a better approach to some of these cases. We know right now that there's a bit of a problem with analgesia in the emergency department. So every few days, there's some article in the newspaper about opioids and about the opioid crisis. We also know that we're probably not very good at controlling pain in the emergency department, and that's probably perhaps one, if not the most important patient-centered outcome that people care about when they're in the emergency department. And then we also know that a lot of people go on to develop chronic pain. So this infographic from the Royal College says that 15 to 30% of people will develop chronic pain at some point in their lifetime. And so maybe there's some different things that we could do besides just using opioids that would help with some of these issues. Why are we talking about ketamine for analgesia? Like, how does ketamine actually work as an analgesic? So this all involves glutamate and the NMDA receptor. So we know that glutamate is released in the spinal cord from the dorsal horn cells in painful stimuli. And we also know that this pathway is involved in both acute pain, but also chronic pain, So there's actually research to show that this pathway is involved with central sensitization, with opioid hyperalgesia, and also with opioid tolerance. So the idea is that hopefully ketamine's action should, first of all, treat acute pain, but also it might even have a benefit in terms of preventing chronic pain down the road as well. And there's, not necessarily the best evidence for but there's a lot of hypothesis generating studies at this point suggesting that using ketamine might prevent chronic pain. Our anesthetist colleagues have been using subdissociative doses of ketamine for analgesia for many, many, many years in the perioperative setting. And so, those studies have shown that ketamine reduces pain scores, and it also reduces the amount of opioids that you have to give to patients. And there's actually a lot of good evidence for this. So there was even a Cochrane review that looked through multiple studies that showed that there's a benefit to ketamine in this setting, its use by anesthetists. What about using ketamine in the emergency department? What's the evidence base for this? And there's two different categories of studies. Some are looking at the combination of using ketamine along with opioids, and some of them are looking at using ketamine instead of opioids. So if we look at the studies looking at using both of them together, you can see that there was about 3 recent studies looking at this. They were all randomized placebo-controlled trials done in the emergency department. They're all of various sizes. So some are, around 120 patients. Some are smaller at around 60 patients. They all, and this is very important to note, they all excluded, or most of them have certainly excluded elderly patients. So we don't have a lot of good evidence for using ketamine as an analgesic in elderly. And they all excluded or had some sort of criteria excluding people with psychiatric problems. Most of them excluded people with schizophrenia and psychosis, but some of them are a little bit wishy-washy on what kind of psychiatric disorders they excluded. If you look at the doses and what they actually did, so most of the studies used a dose of 0.1 milligrams per kilo. One of the studies looked at 2 different dosing, so 0.15 and 0.3. And one of them looked at 0.3 but given a bit slower, over 15 minutes, and we'll talk a little bit more about that in the future. You can see that this was all compared with, given in addition to morphine. So most patients got either 0.1 milligrams per kilo of morphine. One of the studies by Bowers et al. Actually had this opioid protocol that people were getting. But the results are all pretty similar. So like the anesthesia literature, there's a lot of data showing that this reduces the amount of opioid that you have to give. So that's the first thing. One of the studies, by Baudouin, also found that you have this lasting effect with the ketamine. So you get some analgesia for about 2 hours, which they didn't see with the opioid group. And one of the studies, had a greater satisfaction in the people getting opioids and ketamine. If we look at some of the complications that people were getting, so first of all of the adverse effects were very, very mild. And you could see that in some of the studies, there's actually a fair number of adverse effects in the morphine group as well. But most of these adverse effects are looking at things like lightheadedness or dysphoria, those types of symptoms. You could see that one of the studies by Sin et al. Found no difference in terms of adverse effects. So that was the studies looking at really combining ketamine versus ketamine and opioids. What about looking at using one or the other? So there's some studies looking at this as well. So these, again, are randomized placebo double-blind trials done in the emergency department. These were fairly small studies. Again, they excluded the usual suspects with ketamine. So they excluded elderly, they excluded people with psych issues, and they also excluded chronic pain patients. And so the dosing that they were using in these studies was ketamine 0.3 milligrams per kilo, so that upper limit in some sense of the analgesic dosing range. And this was essentially given by IV push, so it was given over 5 minutes or over 3 minutes. And this was compared to using morphine at a standard dose. And basically, all the studies found there's no difference. So you get the same amount of pain relief if you're using ketamine in this dosing range compared to using morphine. And they found that basically nurses and doctors found the same amount of satisfaction as did patients. In terms of the complications, so kind of like the other studies we were looking at, one found no difference, and one said that there was some more of these minor adverse effects in the ketamine group, again, looking at dizziness and disorientation. So one of the things that we could see from looking at that first group of studies is people are giving ketamine in different doses, but probably what's even more important is people are giving it in different ways. So they're giving it over different amounts of time, and some people are giving it by IV push, and some people are giving them as infusions. So one of these studies that was done by Matov actually looked at comparing giving ketamine as an IV push versus giving ketamine as a 15-minute infusion. So what they were doing is they were again giving this analgesic dose of 0.3 milligrams per kilo, and the IV push group was getting it over 5 minutes. I would argue that we're horrible at this. At least doctors are horrible at this. I don't know if people are giving, beta blockers or calcium channel blockers intravenously, and, everybody's always inclined to really give this quickly. So I would argue that if you're giving this, in a syringe, we're probably even giving it faster than 5 minutes. And they compared this to giving it over 15 minutes. So the way that they did this is they just mixed the ketamine in 100 cc's of fluid, and then they gave that either by infusion pump or just IV piggyback. And so the results basically found that you get the same amount of analgesic in both ways, and the same amount of reduction in pain. But you actually get more side effects if you're giving it rapidly, which makes sense because we said that ketamine, will cross the blood-brain barrier very readily. So if you're giving it quickly, you probably have higher CNS levels right away. And so, their conclusion was that there's probably a benefit to giving this slower by an infusion. So my take-home points for using subdissociative ketamine as an analgesic would first of all be that this is like a viable choice in the emergency department. There's a lot of evidence saying that this is as good as morphine. As we saw, you can either give this by itself instead of opioids, or you can combine it with opioids. In terms of dosing, I think that there's the strongest evidence for giving 0.3 milligrams per kilo and to give this over 15 minutes. And then, if you are very, very inclined to give something as an IV push, then it's probably better to use a bit of a lower dose to avoid some of those side effects. So, giving 0.1 milligrams per kilo. And first of all, no monitoring is required at this dosing range. So if you look at that guy, Matov, who's published a lot about that in the States, what they do is people aren't on a monitor. They don't even, I'm not saying that we necessarily have to do this, but they don't even use infusion pumps. They literally just hang it as we would do with Maxaren. And I'll come to questions after, but that's a lot of the evidence is suggesting to not need monitoring and to not need lots of equipment to give this medication. So I'm going to move on to talking about procedural sedation, and I promise that we'll have time at the end for questions, and I'm sure there's a lot of debate around a lot of these topics because some of them are somewhat controversial. So if we switch to talking about procedural sedation, and we start with a case, so you have a 50-year-old who needs a reduction of a trimal fracture, and you're going to do the sedation for orthopedics, and so kind of what agent are you guys going to use? So who would use ketamine by itself, just ketamine, single agent, sedation? Okay, so I'm seeing nobody would do that. What about ketamine mixed with propofol? Okay, so I'm seeing a fair bit of hands. What about propofol and fentanyl? Okay, so probably the majority of people are going to use that. And then propofol single agent, okay, probably no one. Okay, so we'll go through some of the evidence around this, and we'll see if, you guys change your minds a little bit, especially the propofol fentanyl group. So if we talk about using ketamine as a single agent, so it's important to realize that this is used super commonly in pediatric emergency departments. This is probably like their go-to sedation. In adults, we probably underutilize this, and you can see that when we talk about doing ketamine as a single agent, everybody's kind of like, no, we don't want to do that. Lots of side effects, which we'll talk about. So first of all, if you're going to use ketamine as a single agent for a procedural sedation, you should be, again, targeting that fully dissociative dosing range. So there's none of this titrating to effect and giving smaller doses. Really, all the evidence suggests that you should use the same dose that you would use to do an RSI. So using this 1 to 2 milligrams per kilo IV. Or if you're going to use IM, which we'll talk a little bit more about, you could use 5 milligrams per kilo IM. And so the benefits of using ketamine as a single agent is you get a lot of analgesia, you get sedation, you get amnesia. And perhaps more importantly, you get preserved respiratory drive and airway reflexes. And we also know that it's, and again, people that aren't catecholamine deplete, it's hemodynamically neutral. So those all make very good properties to use it as an agent for procedural sedation. Now, when we talk about using ketamine as a single agent, this always comes up, and people always tell you about the bad experience that they had using ketamine by itself. And so what I thought we would do is actually look at the numbers, because there's a fair bit of evidence saying how often these adverse events happen. So we have Strayer that did this meta-analysis with over 70,000 patients looking at adverse events and ketamine. And then we also have 2 studies that were done in the pediatric world. So those were, again, 2 large meta-analyses. One had 8,000 patients, and one had 6,000 patients. And that was actually done by Dr. Bhatt at CHIO, who's kind of like one of the experts on pediatric procedural sedation. So respiratory depression, you hear some people talking about respiratory depression with ketamine. Does this happen? So yes, it can happen. So from the pediatric literature, where we actually have numbers, they think that happens in about 0.8% of people. But what's important to note is that, again, this is related to probably the CNS level. So it's dependent on how quickly you're pushing it and how quickly that gets into the CNS. And also, this is thought to be transient and literally never clinically significant, meaning people don't, become apneic for prolonged periods of time using ketamine as a single agent. What about laryngospasm? So everybody's really worried about that in ketamine. So again, the evidence from the pediatric literature would tell you that this happens in 0.3% of sedation, so a very small number. And it's probably even less frequent in adults. And in adults, the studies that talk about this say that it's even usually very mild, meaning that you can just bag the person. These aren't people that typically end up paralyzed and intubated in the ICU. Hypersalivation we hear about a lot. This is actually exceedingly rare, and all of these meta-analyses essentially found that this is not an issue. It used to be kind of trendy to give an anticholinergic like atropine to people to prevent hypersalivation. That's been debunked, and there's no evidence to support doing that. And then we're getting to the 2 ones that we should be worried about in the emergency department, and those are vomiting and emergence reactions. So vomiting happens fairly frequently. If you look at kids, that happens in about 8.4% of sedations. Now this, again, it's important to realize that the vomiting with ketamine typically happens as the ketamine is wearing off, meaning that it's unpleasant for the patient to be vomiting, but it's not happening when the person is completely sedated. And vomiting in ketamine sedations does not equal aspiration. So we're not talking at all about aspiration. We're talking about people throwing up as they're waking up. And so you can see that, that's even a little bit, depending on the study, more common in adults. There is studies that say that it's much worse with IM compared to IV formulations. And there's also studies saying that Zofran helps prevent this. And then emergence reactions, which everybody is worried about. I've had bad experiences with this as well. If you talk to a lot of the nurses, everybody remembers their really bad emergence reaction that they've had. But if we actually look at the numbers, so in kids, this probably happens around 7% of the time. And they said that clinically significant agitation happened much less frequently, so around 1.4% of the time. And studies have also shown that in kids, there's no benefit to prophylactically giving kids benzos. Like that doesn't actually prevent an emergence reaction. In adults, this is even a little bit more common at 10 to 20%. And there is evidence, which we'll talk a little bit more about, that benzos prevent and treat emergence reactions. So in terms of some of the contraindications to using ketamine as a single agent, so first of all, it shouldn't be used in kids less than 3 months, but that's actually true of any procedural sedation, really, in kids that young. And as we said, you should probably avoid this in patients with schizophrenia. In terms of relative contraindications, so this I didn't know until doing research for this talk, so there's actually evidence to say that you get much more laryngospasm if you're doing things in the mouth or in the posterior pharynx. So there's a study looking at doing EGDs and using ketamine, and they found that there was a rate of laryngospasm of almost 8%. So probably if GI is asking you to do a sedation for a scope, ketamine would not be a good agent to use for that. But it's been shown that it's okay to do procedures in around the mouth, like suture, intraoral lacerations and whatnot. In kids, it should be avoided with URTI. And then finally, we know this is, again, similar to what you would know for using ketamine as an RSI. There's a risk of using it in people that are quote-unquote cardiac cripples because of the catecholamine release that you get with ketamine. So what about these things that we know happen that people have bad experiences with in the emergency department, so nausea and vomiting? So first of all, what I would say is that you could consider using prophylactic Zofran if you're using ketamine as a single-agent sedation, because we know that that works. And then with emergence reactions, so as I said, benzos, first of all, treat that. There's no evidence to giving prophylactic benzos in kids, but there is some evidence to say that that might help in adults. But probably what I would suggest, and we'll talk a little bit more about that, is that if you're going to use ketamine as a single-agent sedation, you should just leave a PRN order for midazolam on the chart when you're done your sedation. That way, if there's any kind of emergence reaction, the nurses can just give some midazolam. Now, probably more relevant to us, because I know we're a big propofol fentanyl center. What about using propofol and fentanyl versus propofol and ketamine? So there's actually a really good study looking at this done by Messenger et al. In Kingston, and they actually looked at exactly this. So this was a double-blind RCT, again done in the emergency department. They were doing these sedations mainly for orthopedic reductions, and what they did is gave patients either ketamine at 0.3 milligrams per kilo, so again, that kind of analgesic dose, or they used fentanyl at 1.5 mics per kilo. This was given like 1 or 2 minutes before doing a titrated propofol sedation. So this is essentially looking at exactly what most of us would use here in the emergency department. The results are kind of interesting and surprising. So if you look at what they called intrasedation events happening, you could see that there's a crazy high number happening in both. Now, it's important to note that in this study, they didn't use supplemental oxygen, so a lot of these intrasedation events were like an oxygen desaturation that's probably of no clinical significance. But if you look at the severe events that happen, and that's what's kind of highlighted in red, you can see it's pretty scary looking at the two different groups. So you can see that in the ketamine group, there was none of these dangerous intrasedation events. And in the fentanyl group, they happened in almost 16% of cases. And if you look on the bottom, you can see what those severe intrasedation events are. And they're actually, some of them are pretty, pretty significant. So that's, an interesting thing to think about. They also found that in the ketamine group, you had to use less propofol. People took less time to wake up. And they also found that there was no difference in terms of satisfaction between the team and the patient. And also for the people that are really worried about emergence phenomenon, so there was 0 cases of emergence phenomenon when you combine both of these agents. So that kind of things to think about. I'm not going to talk a lot about Ketofol because this, initially was thought to be maybe this game changer of mixing everything in the same syringe. This has been debunked. There's lots of studies saying that it doesn't make any difference, and it's a bit hard to rationalize oneself around why you would mix 2 drugs that have such a different half-life in the same syringe. So my take-homes for using ketamine for procedural sedation would be, if you're using ketamine as a single agent, I think that you should give the full dissociative dose. You should consider using prophylactic Zofran and midazolam. But probably what I would do, just because, again, in 80% of cases they might not have an emergence reaction, is to write a PRN order for midazolam. That way the nurses have that if there's any kind of emergence phenomenon. If you're using ketamine and propofol together, we found that there's less adverse reactions compared to using fentanyl and propofol. And there's also much less emergence phenomenon. So we're going to talk now about a bit of a similar, or I guess a related topic, which is using ketamine for agitation. And you can really think of using ketamine for agitation like doing a complicated procedural sedation with ketamine as a single agent, right? Because that's essentially what we're doing. So if we look at a case and we think of, a 30-year-old who comes in super agitated, they had already gotten 10 of midazolam with EMS, so they had gotten a pretty good challenge of benzos in the field, and they're still super agitated. They're being held down by multiple police officers, and so the question is, what kind of chemical sedation are you going to prescribe now? So who would use Haldol? Okay, so I'm seeing a couple of hands. What about midazolam? So, keep on going with the benzos. So I'm seeing a lot of hands. What about switching to lorazepam? So using a benzo but a different one. I'm seeing like a couple of hands. And what about using ketamine? Okay, so we're kind of we're evenly split on all of these agents, which is interesting. So we'll talk a little bit more about using ketamine for this indication. So we know that when we're sedating agitated patients, what I'm talking about is really people with undifferentiated agitation. So not people that they have schizophrenia, they're coming in psychotic, because then I think most of us would usually use antipsychotics for that. But I'm saying, what about using ketamine in people that we don't really know what's causing the agitation? And there's a lot of evidence coming out that maybe we could be using ketamine for this. So first of all, ACEP listed this in some of their recommendations surrounding sedating agitated patients. And then we know from an excellent grand rounds given by Aisha a little while ago that actually ketamine is being rolled out to our paramedics here in Ontario, and they're going to have that at their disposal. So what kind of evidence do we have surrounding using ketamine for these indications? So there's some studies looking at ketamine as rescue. And so what that means is you have somebody, they've already been given all kinds of other agents, and they're not adequately sedated. Can we use ketamine to kind of add that to the other agents to get these people sedated? So there was a case series that was done in 2015. Again, this isn't the best quality of evidence. It's a small case series, but they basically found, okay, nobody became hypoxic. But again, not the best evidence to hang our hat on. There's a better study that was done in 2016, and this was a prospective study. And here they looked at using ketamine for difficult to sedate patients. And they found that, first of all, I'll just mention patients that had already received like 2 big doses of antipsychotics. So again, like you're adding ketamine to the mix. But they found that ketamine seemed to be a good choice. They had 6% of adverse events. Most of these were just, vomiting. And there was one case of an oxygen desaturation to 90% that responded to supplemental oxygen. So these studies are kind of supporting using ketamine. I can't talk about using ketamine for agitation without talking about these studies by Cole done in Minnesota, because their results are just so incredibly different. So these were 2 pre-hospital studies using the same cohort of patients. So they had this cohort of patients that they called severe agitation, and they had this altered mental status scale to kind of rate people's agitation, which isn't really interesting to go into, but they had these severely agitated people, and then what they called these like profoundly agitated people. So the profoundly agitated people are, like uncontrollable. And so what they did is with these severely agitated people, they did this prospective study where they compared using ketamine or using Haldol, so using 10 milligrams of Haldol or 5 milligrams per kilo of IM ketamine. And then with their profoundly agitated people, they just did ketamine. And the reason that they did this is they say that this has been their practice for many years to use ketamine in these people that are uncontrollable, because they thought it's like not even ethical to try using other things besides ketamine. That was their rationale for only using ketamine in these profoundly agitated people. If we look at the adverse events that happened, they're quite striking. So these are the adverse events for both. So these adverse events are super high. They're also very, very different than all of the adverse events that we saw for the procedural sedation, which is interesting. Probably most striking is that it's a bit bizarre, like they had 38% of people had hypersalivation, which I find a little bit hard to believe, especially looking at all the other evidence. So I don't know how they rated that, but fine. But what's really crazy is the intubation rate in these 2 groups. So these are emergency department intubations. These are not people that were intubated in the field. These are people that arrived to the emergency department after being sedated with ketamine by EMS. And you can see that, in the severe agitation group, like almost 40% of patients were intubated. And in the profound agitation, like 60% of these people were intubated. Now, there's a lot of methodological problems with these studies. They say that the intubation rate was super high because there was one night doctor that intubated like 50% of the people. So they're trying to say it was this one doctor that just likes intubating people that have been ketamized, which, I don't know. what to say about that, but certainly it's very different than the other studies, which is a bit striking. There have been some studies that have been done since that are a little bit more reassuring. So there was a recent study that looked at using ketamine in the emergency department for sedating agitated people, and this wasn't combined with other agents. This was like just people getting ketamine. You could see that they compared lots of different agents, and the only thing that I want to point out with this is that the doses that they're using are a little bit small, right? So especially with the ketamine or even the midazolam group, I'm not really sure who I'm going to give 2 milligrams of IM midazolam that's profoundly agitated. So again, that's a bit of a red flag in terms of interpreting this study. You can see, and I didn't mention that with these other studies, that ketamine certainly works fastest. That's kind of like undisputed, that in all of these studies, people will become controlled much more quickly with the ketamine. So in this study, you can see that that happened in about 6 minutes. In some of the other agents, that took quite a bit longer. And then if you look at their intubation rate, you can see that it's much, much, much lower than those studies by Cole. They found that there weren't any changes in vital signs. There were, weren't any, like no one died. I mean, I guess I would think intubating somebody would be a serious adverse event, but it sounds like all the people that were intubated eventually did fine. But there's a lot of limitations with all of these studies, and that's that we're trying to pick out very rare but serious adverse events happening, and we're using very small sample sizes, right? So that's probably not really giving us a good picture as to how often these events happen. So what are my take-home points for using ketamine for agitation? If we're using ketamine for agitation, it should be given at 5 milligrams per kilo, and I would say it is a viable option for sedating patients. I think that larger studies looking at some of these more rare adverse events have to be done before we can really do any strong recommendations. But I personally would use ketamine in 2 different scenarios. One would be if we give a good, like more than one good trial of benzos. So, I'd say for the case that I gave you guys, if he's already gotten 10 of IM midazolam and that hasn't made any difference, that maybe that's somebody to consider doing this in. Or I think this can't be understated, that if this person is just uncontrollable and dangerous, and we know that benzos take longer to kick in, that maybe this is somebody that would benefit from ketamine. So those would be my take-home points for the agitation. So we're moving on to areas where there's like more and more limited evidence for ketamine. Okay, so these are getting a bit more and more fringe, but we'll talk a little bit about using ketamine for alcohol withdrawal. And we'll start off by again, a clinical case. So if you have a 48-year-old woman that is in profound alcohol withdrawal, she's already been given 100 milligrams of IV diazepam, but she's combative and in profound withdrawal. What are the next thing that people are going to do? So, the options are to continue with diazepam, switch to another benzo, intubate and start propofol, or start a ketamine infusion. I'll let people kind of think about that a little bit while we talk about some of the evidence. Why are people talking about using ketamine for alcohol withdrawal? That has to do a bit with the pathophysiology, so that we know that when people drink alcohol repetitively, that you basically get a downregulation of your GABA receptors, and you get an upregulation of your excitatory NMDA receptors. And we know that most of the treatments that we're using for treating alcohol withdrawal, like benzos and phenobarb and propofol, they all work on the GABA receptors, which are downregulated. So people have hypothesized that maybe ketamine would be a good agent because it's going to work on the receptors that are upregulated in this state. There have been 3 studies, all done, or 2 of them have been done this year. And first of all, to point out that these are all ICU-based studies. None of these were done in the emergency department. They were all fairly small, right? So, not the largest of studies. If you look at the populations that they looked at, there was different combinations of things. So some of the studies mostly had people in DTs. Some of the studies had people in severe withdrawal. And they were all looking at using ketamine infusions to be used for alcohol withdrawal. So usually at doses of around 0.2 to 0.5 milligrams per kilo. Now, this is what's perhaps most important for us in the emergency department. These infusions of ketamine were all started like well into people's admissions, right? So they were started, in one of the studies like 34 hours into their admission, or since presentation, and another one 41 hours. So these aren't people that are getting ketamine in the emergency department right away. And so what they found is basically all of the ketamine reduced the amount of benzos that people needed. Some of the studies show that there was actually a decreased rate of intubation. And I guess all the studies showed that there was a good effect of using the ketamine. In terms of complications, so there weren't tons of complications. So in 2 of the studies, there's just one person that was over-sedated that was just treated with a dose adjustment. In one of the other studies, there were a few people that were intubated, but some of those people were actually intubated because they were still in profound withdrawal. So it wasn't really a direct effect of the ketamine. So my take-home points for this is there's limited evidence for using ketamine in alcohol withdrawal. None of these studies were done in the emergency department. And so I would consider using this if are giving crazy high doses of benzos and you're debating intubating this patient for alcohol withdrawal. And in that case, these studies looked at using infusions of 0.1 to 0.3 milligrams per kilo per hour. And by far in the emergency department, benzos are first line for alcohol withdrawal. Okay, so in the last 5 minutes, I want to talk about a very controversial topic, which is using ketamine for suicidal ideation. I've already gotten messages about, you're crazy, why are you mentioning this in your grand rounds? But I'm not necessarily advocating this. I want to talk about some of the evidence behind this. So these are 2 newspaper articles that were published in February of 2017, all around ketamine. And all of these articles are referring to studies done by a doctor at the ROH, so Dr. Pierre Blier, who was looking at using ketamine for treatment-resistant depression. So using ketamine for treatment-resistant depression has become very trendy. So there's actually, was a study done in the 1990s saying that ketamine, actually has an antidepressant effect. And there's a lot of trials since saying that ketamine has antidepressant effects, but it's thought to be transient and only last for about a week. Now, these 2 pictures aren't Photoshopped. Like, there's a lot of, in the States, these ketamine clinics that you can go to receive ketamine infusions to treat your depression. So that's ketamine for depression, and I'm not going to tackle that. But what about using ketamine for suicidality specifically? So there was a study just published a few months ago, which was a double-blind RCT. This was looking at inpatients, so again, maybe not necessarily the same as our setting. And these patients either got 0.5 milligrams per kilo of ketamine over 40 minutes, or they got what the authors called an active control. So they gave a dose of midazolam. And I guess the reason behind that is, if you got saline, you could certainly tell that you did not get the study drug. So the idea was to try to give something that had a bit of, altered perception as well to use as a control. And so what they were looking at is the reduction in suicidality as defined by reducing this score called the Scale for Suicidal Ideation. And they defined responders as a reduction in 50% of this score. And they found that on day 1, there was quite a bit of reduction in the ketamine compared to the midazolam group, with a number needed to treat of 4. Again, this isn't the best evidence. There's a lot of limitations to this study. There's also been, again, published this year, a meta-analysis looking at using ketamine for suicidality. And so this had, a number of studies, 10 studies with over 167 patients total, done in a variety of different settings. So you could see none of them are emergency department settings, but some of them are outpatient, some of them are inpatient. And what they found was that ketamine rapidly reduces suicidal thoughts. It starts to work, I guess, first of all, importantly, very quickly, so within 1 day, and that effect lasts at least a week. And so again, there are limitations with this. So some of the trials in the meta-analysis excluded people with very, very serious suicide risk. So that's an important limitation. And then it's unclear really if these reduction in scales really translates to safety, right, and sending somebody home. So that's the other important thing. But there's been one study looking at using ketamine for suicidality in the emergency department. So this was published in 2014. And so what this was done is like an emergency physician-initiated intervention where the emergency physician was giving people ketamine at 0.2 milligrams per kilo IV over 1 minute. And then they were assessing, again, using these scales for suicidality and also a scale for depression to see what the effect is of ketamine on these patients. And they had done follow-up up to 10 days via telephone. So what they found is that at 10 days follow-up, 85% didn't have any suicidal thoughts. There are tons of limitations with this study. So first of all, there's no control group. It's small. It's done in Iran. So I'm not sure if some of their mental health services might be different than us. And there's a lot of ethical implications between giving somebody this. Are you just making them high and that's making them feel better? Are there, abuse considerations? So there's a lot of limitations, obviously, with this. So my take-home points with using ketamine for suicidality is right now there's no role for using ketamine in the emergency department for suicidality. There's a lot of more studies that need to be done and are actually in progress. There's a lot of logistical and ethical roadblocks surrounding using this sort of intervention. But maybe in the future, if there's a lot more evidence base, it's possible that we would be giving ketamine and then arranging expedited follow-up for a select group of patients. But again, nobody really knows what that group is. So that's it. Here are my references, and I'm sure there's going to be lots of debate because I'm sure people have some thoughts about some of these controversial topics. Christian.